thank you so much for joining us today and for your patience waiting for the start of the meeting. My name is Amanda Woolley, and I'm moderating the session today for the International CML Foundation. I'm really delighted to have you all here today on our very first collaboration between the CML Foundation and the Pakistani Society for Hematology. We are jointly hosting these three key discussions on CML over the next couple of months. Add that we've got Professor Zeba Aziz presenting and Professor Jorge Cortes responding as our international expert. But before I introduce our speakers and we get onto our session, I'm just going to give a brief introduction about the foundation. So the International CML Foundation is a physician and researcher-based organization working towards improved outcomes for CML patients around the world. We work to raise the bar of CML management through education, and that includes our regional discussions like the one today. And over the last 14 years, the foundation has been working via preceptorships, meetings, symposia, and through our online knowledge center, trying to make sure that no matter where you are in the world, CML physicians and researchers have access to the best possible knowledge, opinions, and experience. Our second priority is to harness the power of global research. Our hope is working towards a cure for CML, but along the way, we are also trying to improve treatment pathways and patient outcomes as much as possible. So we have the Genomics Alliance, we have the TFR Alliance, and we also did a lot of work during COVID around CML and COVID, and we have a hepatitis B survey in preparation. We are looking at pregnancy in low and middle income countries, pediatric treatment in low and middle income countries, and much, much more to come. That's our brief introduction to CML, if you are not already familiar. And today I am really pleased to get the opportunity to introduce you to our long-term treatment-free remission and CML. Is it feasible in low and middle income countries is the question.
May I have 1 minute, please?
Hello, Mehreen, yes.
I am Professor Mehreen Khan, the Secretary, Pakistan Society of Hematology. I am really honored by in this collaboration between International CML Foundation and Pakistani Society of Hematology. And it is a great opportunity for us, the physicians working in a low and middle income country like Pakistan, to be available to world experts like Jorge Cortes and Professor Zeba Aziz. I am fortunate enough to have attended preceptorship program with Dr. Jorge Cortes in 2018 in MD Anderson Cancer Center, Houston, Texas. I'm really honored, and I hope this collaboration would go a long way. Thank you very much, Amanda.
Thank you, Mehreen. That was fantastic. Thank you for that introduction as well. I really appreciate it. So I would love to speakers here today. Firstly, Professor Zeba Aziz, who is the head of oncology in Hameed Latif Hospital in Lahore. She is a great friend of the foundation. She is on the foundation's South Asian steering group. I have been to force at meetings and in discussions. She is always there when we need to know something or find someone anywhere in South Asia. She's very witty and has the best. She's a great leader and always very generous with her time. Zeba, we thank you so much for joining us today and everything that you've prepared to share with us. And our international expert who will be in discussion with Zeba is Professor Jorge Cortes, who is described as a giant in the CML field. He's preceded by his reputation. It's an honor to have you with us here today. Professor Jorge has been a board member of the International CML Foundation for many years and is currently the chair of the board. He is the head of the Georgia Cancer Center in Georgia, USA, but for a long time he was also at the MD Anderson Cancer Center in Texas, where he received very many iCMLf preceptors, as Mehreen already described, and I'm sure that there are potentially more of you in the audience today. This is Jorge's first appearance at one of our regional discussions, but I hope it's the first of many opportunities for our community, our international community, to learn from you, Jorge. Thank you so very much, both of you, for joining us today. Zeba, I would like to pass over to you next. If you would like to share your own slides, I will stop sharing here. And Zeba is bringing us today first some research that she has been completing and also a patient case. And we'll have a discussion around both of those. So Zeba, over to you.
Thank you. And I really thank the iCMLf Foundation and Nicola, all of you, Arlene, Amanda, Stephanie, and most of all, Jorge, for being here. I'm really proud and honored that he's come here to attend our first session. Maureen for organizing it, and thank you, all of you. So what we're going to do is to discuss the long-term treatment-free remission in chronic myeloid leukemia, and is it feasible in our part of the world? As you know, Pakistan is a low middle income country, and the average I mean, it's a very low, on the lower area of the, and there are a lot of marginalized population. 40% of our population earns $1 a day. So if you think about it, it's very difficult to treat cancer here in Pakistan. And as such, cancer is always expensive, people go bankrupt, and there are a lot of problems. I would like to thank Max Foundation because they've started an access program in Pakistan, as a result of which treatment for chronic myeloid leukemia has become great. Now, let me start with my first slide. Let me start with my first slide here. And what I would like to show is that chronic myeloid leukemia in the last century, which was up to 2000, had a dismal prognosis. People didn't live long. We treated them with hydroxyurea, Ara-C, later with interferon. But what happened was that they generally died within 2 or 3 years. It was only in the early 2000s when imatinib became available. In Pakistan, it became available around 2004. And since then, the lives of our patients have changed. They are living a longer life. They are being rehabilitated in their own jobs. More than 90% of patients are working full-time now, and they're happy. So as a result of which, I'm really grateful to iCMLf for bringing everything to our part of the world. Today, when we look at CML, and even in our part of the world, what do we look at? We look at the survival outcome of our patients. We look at the treatment-free remission. We look at the safety. What is the long-term safety of these drugs, and how safe are the patients? And also, we look at what good treatment values are. When we look at the treatment-free remission, which is one of the challenges which we have here, is how do we go about it? There are 5 TKIs which are currently approved. The survival of patients with CML is similar to that in some populations like Finland and Europe, similar to the age of normal patients. 50% out of 100 patients are expected to have an optimal response. And of these, 40 to 45% of patients with deep responses are eligible for TFR. And from there, about 20 to 40% will meet the criteria, and these are the patients who will be off treatment from any TKI. And the current focus in this day of age is on achieving treatment discontinuation. We call a lot of patients, few are chosen, but the rest of them require lifelong treatment or long-term therapies. Generally, there are a lot of long-term problems which occur in Europe, North America, where patients are older. But in our part of the world, the median age is around 38 years, 40 years. So the side effects of drugs are less than what we see abroad. So the challenges which happen sometimes are edema, cramps, diarrhea, kidney failure, cardiovascular events. But majority of the patients in our part do hang on to taking drugs, and very few discontinue it. So recently, in the last 15 years, we've seen some treatment-free remission studies coming out from Europe and North America. The Euroski study, which included 758 patients from 11 countries, and of them 94% took imatinib. And in patients who had a sustained MR3 for greater than 1 year and had taken TKIs for greater than 3 years, molecular response, long-term TFR was 50%. Similar things was seen in the STIM-1 study where imatinib was discontinued in 100 patients with sustained undetected molecular, deep molecular response for at least 2 years. 61 patients lost their molecular response after discontinuing, but the two major things which we learned from this study was that if you had a progression of, or if you lost your molecular response after being treatment-free, you could re-achieve it provided that the patients are more closely monitored. And that is one of the problems which we face in our part of the world. What we saw was in all these studies, none of the patients experienced a CML progression. And the two things which were significantly associated with relapse were the so-called risk score and the duration of imatinib treatment. And this is what we looked at, and we thought, can we do it in Pakistan? And it was a difficult thing and a difficult decision for us to look at and say, okay, let's see what we can do. We looked at a previous study, which we had published several. First one with Timothy Hughes, because he had helped me a lot with that. And the second one was in the Japanese Journal of Clinical Oncology, where we looked at the sustained superior long-term outcomes in chronic phase chronic myeloid leukemia. We found that the greater than 80% had a low intermediate score. Projected event-free and overall survival was 79 and 86 months. Very few patients had intolerance to imatinib, and significant side effects were not noted. The median age was much younger than what we saw in patients from the West. So our problems were, we were monitoring our patients by FISH, which will only give you a cytogenetic response, complete cytogenetic response, but not a molecular response, because it is much cheaper than doing an RQ-PCR. It was irregularly performed because whenever the patients had the money, they would do it. So there was no, like you have to perform it every 6 months, 1 year, there was no timing. It was just performed when they had the money. And are our patients ready for a TFR? Are we ready for a TFR? More importantly, are we prepared to commit ourselves to monitor these patients closely and not let them relapse and go into a blast crisis? Are our patients committed to an extended follow-up when we put them on a drug? And many patients will drop out due to financial constraints because we need to monitor the PCR regularly. And this is what the problems were. We thought about it very long and hard and said, can we do it or not? And then we decided, yes, let's try it. This was done quite a few years back, and we looked at all this. We said that not 3 years, but 9 to 10 years, because we didn't know how our patients would behave. So we took our patients between 9 and 10 years on imatinib in the chronic phase, and there should have been no dose change. Now, slightly different was the complete cytogenetic response for 5 years by FISH. And we said, okay, these are the patients we'll take. And what we'll do is we'll do an RQ-PCR on them twice, 3 months apart, and see if we have an MR of 4.5. And this is the group which we'll take. We also wanted to ask the patients about their willingness and ability to comply with the scheduled visits, treatment plans, lab testing, and everything else. The study design was quite similar to the one which was in the West, except that we started putting the interval more and more, and we followed these patients for 3 years only. After that, they're still coming right now to us, and we are monitoring them. And as you will see later, that we have been successful. We looked at 100 patients and who had taken imatinib for 10 years. And we said, okay, let's do a workup on them. Out of these, 40 patients refused to participate. I was very surprised when I saw that, but one of the major reasons was that Max Foundation was providing the drug free of cost. So if a poor patient is taking a drug free of cost and he or she's quite happy and they don't want to sort of take a risk and they are working in their jobs, their children are growing, they have no problems, why should they participate in a study? I mean, it doesn't make sense. And I'm not sure if I would be ready to participate in a study if I was poor and I'm doing well. So anyway, the reasons for refusal were fear of relapse. They were not sure, even though we tried to convince them that yes, into the access program, they were very scared. They didn't understand. They didn't know I mean, if you're uneducated and if you're not earning well, you don't know, you're lost. And despite explaining to them, they didn't really want to do it. Financial constraints, I'll come to that later in my next slides. And as imatinib, I already said, had minimal side effects. Why should you take another drug? Why should you stop it? And family pressures. Now, family pressure is a very important thing. The wife is saying, don't do it. The family is saying, you're fine. What is the reason? Because the financial problem was that the study was not funded. We had asked Novartis, we had asked a lot of people, but nobody was willing to pay for it. So it had to be paid out of their pockets, and we arranged for discounts. We tried to do what we could, but still, this was one of the major problems, that if you're going to get an RQ-PCR done, you had to do it out of your pocket. So this is the summary of the trial. We screened 60 patients and 31 patients were screening failure. Now, this was because they were being managed by FISH testing. And when you do a deep molecular response testing by RQ-PCR, 31 patients failed. 29 enrolled and 5 patients withdrew their consent because when they went home, the family said, no, nothing doing, you stay on the imatinib. So we put 24 patients on TFR, and imatinib was restarted in 11, while currently the 13 patients are still on TFR and coming to us regularly. This is the swimmer's plot where we show that what is happening. And what you can see, the results are quite similar to what we see in the Western world. And if you do it carefully, and if you do it and the patient and the doctor is committed, we can do it. So we were very happy and proud of ourselves, but we only had very few patients. And when we looked at the economic evaluation, IM was accessible to the patients, 9 months provided by the Novartis and 3 months by the government of Pakistan. The patients bore the cost of laboratory assessment, travels, etc. If we were able to do a discontinuation study and more patients could participate, the government would save a lot of money and more patients could be enrolled. But our patients are refusing and very few patients come occasionally. So one of the conclusions we had is conducting prospective trials in low middle income countries is very bad, very difficult, especially without logistic and financial support from the government and the industry. We face significant obstacles to conducting clinical trials, and we were able to enroll a very small number of patients. We achieved a treatment-free remission in approximately 45% of our patients participating in the study. So basically, this is what we have, and I think we should just go to the discussion. Amanda?
Yes, yes, please, Zeba. I think this seems like a great moment to just pause and reflect on your research that you've been doing. I'm very struck by your humanity in doing this research as well. There's a lot of social elements to consider in this too. Jorge, I wonder if you're available to come in at this point with any of your thoughts, anything that struck you, or any questions for Zeba.
Yes, I thank you very much, and thank you for the presentation, Dr. Aziz. This is actually to me a very attractive study because we were talking a little before we started the actual meeting here that trying to overcome the limitations that are not evident when you just look at the literature from studies like the Euroski and the STEAM and all of those. It is very important. There's a couple of things that I liked a lot about your study. One is the reasons why people don't want to stop. these are real reasons, and these are things that are part of why TFR is not available to everybody. We're not, our patients are not yet ready to embrace these. I'm sure if everything was perfect, all the patients would like to stop their therapy, but things are not perfect, and they fear things like, am I going to be able to get the medication again if I need it? The fear of the relapse and understanding what that means, even the pressure from the family, those kind of things. So some of these things we can overcome by education, which we need to do a lot. And I think that working with the Pakistan Society of Hematology, the International CML Foundation, we evidently need to do more about educating our patients about this. And let me tell you, I experienced that also in my practice. Some of that may have to do with, these are patients who started their TKI long time ago when we didn't know about this and we didn't tell them about the possibility of stopping therapy eventually. When we started doing TKIs, we would tell the patients, you never have to miss a dose and it's very important and all of that. So they were brought with that idea. Now, every new patient that I start on therapy, I introduce the possibility of treatment-free from the very beginning, so that they understand that that's a possibility. And I think that's going to make some impact in overcoming that fear. But there's many other things that we have to overcome. The other thing that I really liked was the very smart design that you did on this study, because of the limitations that you have, basing it on the fish as the primary criteria, which is something that's more accessible and was already there for probably many of these patients, and then just a final confirmation with PCR, but more in more recent tests a couple of times. I think that makes it more applicable to more of the population than expecting that everybody's going to have had PCRs for many years. I think that was very smart, and it opened up the study to more patients. Yes, it is a small study, but in the context of what we know about this approach in populations with more limited resources, it's a very valuable study because it teaches us how it can be done. We could even explore other possibilities. For example, there's been some suggestion, some modeling that you could do the PCR once you stop therapy, perhaps every 2 months instead of every month. And that can make it a little less onerous on the patient. So I really liked your study. I really think that this is very valuable, and it in helping other patients, other physicians in situations similar to what you live with in Pakistan in terms of resources, patient education, access to medications and to testing, those kind of things. It is very informative in that regard. So congratulations.
I'd like to thank you for it, but I also would like to ask you, is there any way to improve all this other than doing a PCR every 2 months, which I think we were planning to do, and we've started doing it outside the clinical trial? But how do we convince the patients who are getting the drug free of cost that no, and the patient is not educated? It's like, it's a very difficult time, and they have to pay for the PCR. So they say that this is so expensive. Why should we do it? Why should we commit ourselves to this, that way? So, but that's life, and I don't know what to do. And this is what is happening.
These patients are getting the medication through the Max Foundation?
Yes, it was. Now we've gotten a local drugs, because the dollar was becoming very expensive for the government. So they've gone on to the local generic imatinib. And I'm not sure, I'm going to try and do a generic imatinib study on this and see how successful we are, because there are some reports that generic imatinib is not as good as the Novartis imatinib. This study was done by the drug which was provided by imatinib, by Novartis. And the patient does not pay for anything.
Well, I think that one way to do it, if now the patients are getting the medication through just the generic imatinib, why are they concerned that they would not be able to access the medication if they need it? Because it would be the same prescription process, or am I missing something?
No, it's the same prescription process for the iCMLf Foundation also. The Max Foundation was also giving it to them. There was no problem. It is just the fear of losing out. And the fear, it's very scary. If I was not educated, if I was not confident, if I didn't know anything, for a poor person, it's very difficult to think of losing their job, of thinking of being uncertain in life. Poverty is uncertainty.
One possibility would be to do patient education activities that are directed to a large group of patients. Sometimes it may be that the patient, when it's a one-on-one interaction, even when they have a good relationship with you, it's such a big decision that I may fear that there may be something deep that they're not understanding, that you're not telling them something, whatever. But if we were to plan educational activities for patients, where it's a discussion that is generic, you're talking to patients that are yours and patients that are not yours, that it's just a general education, very simple, where you spend enough. I've done some of these in Latin America, and I've done them in Latin America because I do them in Spanish. That way, it's easier to communicate directly to the patients. I can answer their questions directly and that kind of thing. And they tend to be very successful because it's a very relaxed thing. I give a presentation at a very slow pace, using very simple terms. I have a very long time for question and answers, 2 hours to answer all their questions. During lunch, I'm having lunch with them and all of that, so that it feels more of a conversation and all of that, and doing repeatedly, because again, it's just breaking that barrier that, when they first hear about these, it sounds like a big change from everything they've heard. So I think it's just going to take a lot of effort of doing more and more and more of these things, so that the patients start feeling more comfortable with that. Now, there's always going to be a subset of patients that do not want to stop, and you don't want to force anybody. But I think that with education, we can make it from perhaps a minority or only half to a majority, with the ones who don't want to do it more of an exception. Maybe something like that we could plan together and see what can be done.
Yeah. I'm sure one of the major problems is that we see an average of 100 patients in 3 hours.
Yeah.
And
wow.
you have to start, of which 30-40% are new. So the doctor who's doing it hardly has the time to look at the CBC and write a prescription.
Yeah.
Now, what
It
you're
would be
talking
great.
about is a totally different ballgame of going and giving
It would be great
talks.
to come back to this discussion about patient education at the end as well. And I would like to encourage our audience, if you have questions or you have ideas about that topic or any of the other topics that Zeba and Jorge have touched on, please please feel free to put them in the chat now so we can come to them in the discussion, or just hold on to them to jump in at the end. But it would be great at this point if we could also hear your patient case that you brought, Zeba, and a live example, and see how that applies to your specific case that you've brought to share today.
Can I ask a question, Amanda?
Sure, Maureen, jump in.
Yeah, thank you very much. My teacher, my wonderful teacher and my role model, Professor Zeba Aziz, who is the pioneer in oncology and CML treatment in our country. And thank you very much, Professor Cortes, who was my mentor at MD Anderson. So I have a question. I have two questions, in fact. The first question is that very rightly pointed out by Professor Zeba, our patients are afraid of trying TFR because the drug is free and the RT-PCR, which we have to advise, is quite expensive. So my question from Professor Cortes is, as you said, we can repeat PCR after 2 months. Is it possible that we extend it further and repeat it after 3 months? One question. And the second question from both the experts is, what about cryptic translocation leading to CML? This is translocation 922, but this is cryptic and cannot be picked up by PCR, and for which we have to perform FISH. So I have a handful of patients who are being monitored by FISH only because that translocation cannot be picked by PCR. So what about them? Literature says that the cryptic translocation should not be offered TFR. So what is your clinical experience, Professor Cortes and Professor Zeba?
Dr. Aziz, you want to go first?
No, you go first.
Okay.
Because I don't do TFRs on cryptic transformation and just stay away from it.
Well, first in terms of the frequency of the PCR, I do think that in many instances, to make this a reality, we need to find a balance between what is optimal and what is practical within the context of keeping the safety of the patient, of course. I think that, we talked about the 2 months, and I think that although I still do it every month, but I do it in patients that have insurance and they don't have to worry and all that. So that's very different. But I think that 2 months is actually very safe. I think it'll be worth exploring an approach of every 3 months, or even, let's say, the first one you do it in 2 months, because we know that the highest risk of relapse is the first 6 months. So maybe you do the first one in 2 months just to capture that patient that very quickly is going to bounce back. And then you go right away to every 3 months and do that for, let's say, the rest of the year or something like that. Do as little as possible and see what happens. I honestly think that that'll be safe because it really only matters when the patient loses the major molecular response. And even if it's a little bit higher, let's say it's not just that they went to 0.2, but they went to 0.8. That's still okay. The patient's safe. They're going to need to resume therapy, but they're not in any immediate danger. And we know that nearly all of the patients respond. So I think that this is worth exploring, and I would think that it's very likely to be as effective and could be a way to do it in settings where doing it more frequently is difficult, because it's not only the cost. Sometimes patients have to drive or travel a long distance to get to the place where they can be done. And that's not easy to do for everybody. So it's not just the cost issue. There's many other considerations that limit the access to PCR to everybody with that frequency. In terms of the non-typical transcripts, we don't do it also because there's no good way of monitoring, and the gap in sensitivity between a PCR and a FISH is too large to be confident only with FISH, which you can do with for the atypical transcripts, but I don't think that's good enough. So I don't do it, and that's there are possibilities to do a PCR that can give you some quantification. It's not standardized, but there could be quantification of atypical transcripts. But again, those are very specific. They're only in selected institutions. So I don't think at the moment we have an answer for those patients.
Can I ask a question away from you? Just one question, quick question. Does iCMLf Foundation, is there a future of clinical trials in low middle income countries which you could support provided the trial is good and you could spread it to the other countries, not just one country? Is there anything which you plan to do in the future so that we have real world evidence where majority of the patients will be living in the next couple of years? Like, it's just a question, it's just a thought that yes, we could do it. And since you're the chief of global hematology and you're the president of iCMLf Foundation, I think research is one of the most important things which is not being done properly in our part of the world. And if there is a forum where you could help the researchers and bring them together so that it's not just one country that does it, but that protocol is spread over 3 or 4 countries who can do it, whoever is willing to accept. And maybe we could get some better answers to research in that part of the world.
We would love to support the research. This kind of research, for example, would be fantastic. Our problem is that our budget is limited, and to support these trials takes a lot of financial input. We do have, however, a TFR alliance where, and this is not a prospective study, but it's a chart collection of data of TFR from all over the world, so that we can learn about, in larger sets of patients, what's happening. I think what we need to do, and I think that's a very good action plan taken from your suggestion, is be more intentional in including patients from low and middle income countries. Because right now, mostly what is represented in our database, in our collection of data, is the traditional countries that you already know about from the literature: the US, Western Europe, Australia, Japan. We do have maybe one site from Latin America, but we need to have more of these data, like your data, from low and middle income countries, so that we can see the contrasts, the limitations, and be better prepared to act on these. Now, the other thing that we're doing is we just started in our last meeting of the International CML Foundation a discussion about creating a more intentional approach to improve the outcome, the TFR, and part of that is just saying, even in the best case scenario, it's only a reality for maybe a quarter of the patients, because not everybody meets the criteria, and of those who meet the criteria, many relapse. So it's a reality for very few anyway. So how can we break that barrier and improve it? But I think that what you mentioned is important that we incorporate. It's not only the biologic barriers, but also the social and economic barriers that they make these not a reality for a large part of the world population, where some of the aspects are not about finding a new drug or a new gene or something like that. It's just education, the monitoring. So they're look at the whole spectrum of barriers to make TFR a reality. I definitely want to bring that back to the team that's working on these, so that we include that as part of our research elements to investigate.
Excellent. Such a rich and interesting discussion. Thank you both. And thank you, Mariam, for your question. And to others as well, please do put your questions in the chat. I would like to move us on now so that Zeba can present her case, and we have a few minutes for discussion on that at the end. So Zeba, please continue.
Okay, we have a 35-year-old dermatologist who's 35 now. She was diagnosed in 2000. She's 35 today now. She's diagnosed in 2009 with CML with fatigue, low-grade fever, massive splenomegaly, which her physical examination showed. Hemoglobin at that time was 11.4, white count was 49, platelets were 74,000, and so-called score was high. We started her at that time since nilotinib was not available on imatinib 400. For 3 years, she was regular with imatinib, and her she could afford it and she was becoming a doctor, became undetectable. She then got lost to follow-up and came back in 2017 after 4 or 5 years, and she had been non-compliant on imatinib. Now her molecular response fluctuated between 0.1 and 0.026, and she again refused to switch to the second generation nilotinib, which was available. She also refused. I asked her to go on if she wanted imatinib and interferon, when there was a study from, I think, UK or somewhere, where the responses were better when interferon was added to imatinib. She said no. And currently she's taking imatinib on 800 milligrams. During this time, she got married. Her significant problems are, again, non-compliance, infrequent and irregular follow-up, and she refuses second generation imatinib. She came with her husband a couple of days ago, and she has been she wants to get pregnant, and she wants to start her TFR before her pregnancy, because she doesn't want to just get pregnant with imatinib while on board. I didn't know what to answer, and I told her that this is not feasible because she was not in deep molecular response. But these are my questions. Can we freeze her eggs while she's on imatinib 800? Have TKI levels been monitored in the female follicles? I can try to reconvince her to go on a second generation, but I think her husband is fed up and he wants to have a child. This is going to be very difficult. And if she does get pregnant while she is not in molecular response, should we go back on imatinib? Would it be safer, or go on dasatinib or some other drug, which is a second, or asciminib, which is available now? I'm not sure what to advise her. I told her that I'll discuss it with you since I knew you would be available for this meeting. And how should we go about doing this? For I don't want her to get divorced from her husband. I don't want her to get pregnant while on this. I'm not sure what to do with her.
Thank you, Zeba. It's another great case showing your sensitivity to the whole person. It's lovely to have this. Sorry, Jorge. What's your response?
Remind me, what is the most recent PCR?
It was, wait, I'll just tell you. Her most recent PCR was, I think, 0.2.
0.2?
Yeah, 0.026.
Or 0.026.
Yeah,
okay.
But like, it fluctuates all the time. It depends on how much drug she takes. I'm not sure what she's doing.
Well, there's two ways that I see you could manage these, and some of that depends on the patient. It is unfortunate that the patient has been non-compliant, and that limits some of your options. But one possibility would be to say, well, we can do this, but we need your help. I think that it is possible that nilotinib would improve the response, and you haven't been willing to take the nilotinib. Well, that would be an option to try to get you deeper into a response and do this safer. But evidently a lot of that will depend on the patient's I think that sometimes we need to work with the patients to tell them part of the work is yours. It's not just what the pill can do or what I can do. It's what you are willing and able to do. So that would be one approach.
Her question is, I saw her and I said that we can put you on this thing. She said you'll take another 3 years or 2 years to put me in deep molecular response, and my eggs will go away by that time. I'll be 38 or 37. So the question was, what should we do now? Can we freeze her eggs?
Well, but not necessarily. I mean, you could potentially do it in a year. Now, so that takes me to the second approach. Many times, we see these situations where the patient either wants to become pregnant at that time, whatever the response is, and they, because of their age or social circumstances, whatever, they want to do the pregnancy in a short period of time, not wait a few years, or they even become pregnant and without even telling you or discussing with you, they just become pregnant, and now they're asking you, what do I do now? So what I've done in these situations, if that is the case, well, then you have to stop the TKI. She fortunately has a reasonable response, 0.026, and even with the fluctuation to 0.1, that is a reasonable response. What I would do is then say, okay, well, then stop the therapy as you attempt to become pregnant. And then we will monitor your PCR. My approach has usually been not to do anything. And yes, the PCR is going to go up, but as long as the patient is fine and the baby is fine, I don't give them anything. And if the PCR goes high, if it goes to 1, if it goes to 10, if it goes to 80, I don't do anything. Usually the patients are going to be fine. Usually the babies are going to be fine. And then when the baby is born, I resume therapy. Now, sometimes even they lose their hematologic response and their white cell count starts going up. Again, if the mother is fine and the baby is fine, I don't do anything. Now, on the third trimester, it's fairly safe to resume therapy if you had to. Let's say the spleen starts getting very big, the patient starts becoming very symptomatic, something else. Maybe even in the second trimester, there is safety on using imatinib already. So there's a possibility of doing that. There are some suggestions about using interferon. I don't use interferon, and the reasons for that are it's toxic. It causes a lot of side effects. It is also expensive, and it takes too long to work anyway. So you really don't get much of a benefit. It's more of a feeling of doing something, but you really don't get much benefit. So if I had to do something, I'd prefer to resume the TKI in the third trimester if needed. But in the great majority of my patients, I haven't done anything. And yes, the PCR is going to go up, but I recently had a patient, and by the end of the pregnancy, the PCR was very high, 40 or something like that. But she was fine, and the baby was fine, and the baby was born fine. I even allowed her to do breastfeeding for a couple of months, and then we resumed therapy. And the patient is now back in a deep molecular response. So that may be the best approach for this patient. Now, the patient has to understand there's a potential risk there, but if she wants to do it now, that's probably the best way to do it.
Should I tell her to go off therapy while she's trying to get pregnant, or should she continue with this?
I usually do. There's no perfect guidelines, but usually 2 to 3 months before stopping the imatinib before is probably the safest thing. Now, many patients become pregnant while on imatinib, and it doesn't seem to affect the baby. So I don't think it's mandatory, as long as you stop the imatinib once the baby, once you know that the patient is pregnant. Yeah.
That's great.
Thanks. This is important.
I hope that was useful for you, Zeba. I'm really keen that we have some time for other questions as well. There's a question already from Maheen. Thank you, Maheen, for your question. Would you like to come off mute and ask your question yourself? Or I can read it out. I'm not hearing Maheen. So
I have a question from Professor Cortes. Thank you very much, Professor Zeba, for a very interesting...
Maureen, sorry, can I just interrupt you there? Can I just ask Maheen's question and then we'll come back to you straight after? So Maheen was simply asking that in Pakistan having CML in all age groups, what's the age group mainly affected in developed countries? And why is this disease becoming more common these days?
You know, when we look at the official statistics in the databases that are for the country, the median age is still listed as 66. But I think that's not representing the reality. We are seeing younger patients more and more. So I do think that the median age is lower than that 66. But I do think that in low and middle income countries, the patients tend to be younger than in the US or Western Europe. If you look at the studies, most of the studies have a median age in the mid-50s. Now, that could be a little bit of a referral bias, but I do think that it is I don't think it's 66, the median age. I think it's at most 60, if not younger, in the developed countries.
Great, thank you, Jorge. And any thoughts on why or if the disease is becoming more common?
Well, I don't know if it is more common. You know, there's definitely a higher prevalence because patients live longer. The incidence doesn't seem to have changed. We just see them more because they accumulate in our clinics. You know, every time we diagnose one patient, it's very likely we're going to see them for many, many years. Whereas in the past, we would see them only for a few years because the median survival was 4 or 5 years. So I think that some of that is just the increased prevalence, not so much an increased incidence.
Great. Thank you, Jorge. Maureen, thank you for your patience. Do you want to come back in now?
Thank you very much, Amanda. Thank you, Professor Zeba, for real-world experience and a very common case which we come across in the clinics. My question from Professor Cortes is, I work in Armed Forces Bone Marrow Transplant Center, which is the largest transplant center of my country, and we have done the maximum number of CML transplant, that is more than 100. So we were doing transplant in the chronic phase 2 decades ago because the TKI lifelong was much more expensive than transplant. So we used to transplant everyone. But now with the availability of TKI, it is more limited to those who are intolerant or resistant to TKI or advanced phase, that is accelerated or blast crisis, whether it be myeloid or lymphoid blast crisis. So my question about the same case is, when such women visit our clinic, in my clinic, what I do is non-compliant patients or patients having questionable regularity for TKI, I usually put them in pregnancy on interferon, and I've had a good experience because that is once a month. The PCR quantitative remains the same in 5 to 6 pregnant ladies whom I have prescribed interferon in the pregnancy. And after they deliver the baby, I put them on TKI again. So is it a right approach for this particular patient? Because in this way, she'll be coming to the clinic and would be getting interferon. And after she delivers the baby,
okay, Jorge, very quickly, have you got some
again for it's right?
Oh, sorry, Maureen's just cutting out. But very quickly, Jorge, because we're running out of time. What is your advice?
I mean, it is the right approach in the sense that it's keeping the PCR stable. But you know, in my experience, when I don't do anything and the PCR goes up, nothing happens to the patient. So I don't worry too much about the actual number as long as the patient is fine. So it's definitely an option, and no question, many use that as an approach. It's acceptable. It's reasonable. Um, but you know, I haven't used it just because I don't see that there's much of a difference with just observing and you know, not worrying as much about the number, but about, you know, whether the patient is doing well. So, you know, both options are possible. I think you can tailor it to your practice, to your patient, to your availability, et cetera, and find what works best for the patient.
Excellent. Thank you. We are almost out of time. We do have two more questions in the chat. I think what we will have to do is move those into our offline discussion. If Professor Jorge, Professor Zeba, if you are happy with this, to have a look at those questions and maybe write a response that we can then share to the participants today, then that would be really helpful, because our time, unfortunately, is finished for today. But I do hope that you will all be able to join us. Yeah, so we're hoping to see you again in about a month's time on the 13th of November at 7 p.m. for treatment of CML in children and young people. We'll have Professor Tariq Ghafoor with us, who I think is joining us here today as well. So if you want to put your camera on, Tariq, and give us a wave, that would be lovely. And we'll be joined also by Professor Nabuko Hajia from the US. And looking further ahead, a date for your diary as well is our third conversation that's going to take place on December the 11th, talking about CML post-BMT relapse. Please do keep in touch. As we've said, questions now in the chat, we will try and get to and share them with Jorge and Zeba, and I'm sure they'll be very generous to give some response to that. And to share it, you will have Arlene's email address from when you have received the details. Sorry about that. And please do share any more questions there and get into. You can also go online and use the knowledge base on the CML website. And also, Jorge mentioned before the TFR Alliance, and there is details of that on the website too, if that is something that you will benefit from having a look at. And other than that, that just leaves me to say thank you so much for joining us for our first meeting. Jorge, you
Amanda,
look like you want to say something. Please
yes,
do.
Can I have 1 minute, please?
Sure.
I was going to mention the TFR Alliance, you already mentioned, but I'm going to share my slide because I also want to remind all of the audience of this new journal from Blood that we are launching, that's called Blood Global Hematology, with the intent of this journal being to give a forum to the research that happens specifically in low and middle income countries, or about populations in low and middle income countries. The idea is that we will publish the research, the commentaries, the editorials, the patient population characteristics, etc. We are constituting the editorial board almost exclusively from investigators from low and middle income countries. We have a couple of them, including Dr. Aziz and the editorial board from Pakistan. There's going to be no submission fees. The publication fees are going to be adjusted to the income of the country. So it's going to make it a lot easier. The site is going to launch October 23rd. So stay tuned, because this is precisely to give a place to the to publish the research kind of like what Dr. Aziz presented today. So just wanted to very quickly mention that and make you all aware of this new journal.
Thank you so much for sharing that, Jorge. That's really important and really relevant to our discussion today. Other than that, so just once again, thank you so much to both of you. Thank you to everybody joining and all your questions. And I look forward to seeing you again in a month's time. Have a great evening. Take care. Goodbye.